Okay, so good afternoon, everyone. So this is the last lecture, and this is an extra session. This is not completely new to you because it's something that we have addressed in every single design, but yet we did not address it in the appropriate level of depth in the designs. And then it actually serves as like a culmination, as a reflection on everything. So it does integrate a lot of what you have taken so far. You might even find maybe one or two slides that you have seen before. And I think this is fine because it will actually give you some new information, but it will also strengthen and emphasize some other information. So we're talking about today our biases in epi study and understanding the lack of validity. So why biases? Because when we think about the concept of biases, this is exactly what in this article says. It's the lack of internal validity. And the lack of internal validity, meaning that we lack the truth. And this means that whatever association we get are incorrect assessment of the association. So if we do a relationship between an exposure and an effect, and my estimate or statistics is biased, it means that I'm not getting the truth. So it means that this is not accurate, this is bias. And bias can be classified by the research stage. So this means that, okay, so it can be at anywhere. So we can have a pre-study bias where you actually define your measure, when you conceptualize, when you think about the sampling, even before implementing the sampling. And this is where your sampling method might be biased even before implementation. This is in the planning phase. And then while preparing and defining your measure, you could build some measures that are of low reliability and low validity, and therefore we're not giving you the proper information, and therefore this might lead to bias. Bias can occur at the stage of implementation of your study, meaning that you could have beautiful plan, but something goes wrong in the field, and then you lose people in a way that's not random. You don't have access. Your trainer or your data collectors might not be well trained, and therefore they might do some error while collecting the data. So data collection issues in the field. And then there's also the issue of the data. So and during implementation, people refuse. So you approach them, they refuse. They withdraw. So all this is part of the implementation or data collection phase, or actually the implementation when you put your study into practice. This is what we say. And then when biases can as well occur when you use inappropriate statistical tests and you misinterpret the result. For instance, you have data that are not normally distributed, and you're using parametric method, for instance, or you do a mistake in recoding the data or coding the data, or using the appropriate method without, for instance, checking some of the assumption. And of course, there is the issue of also misinterpretation of the result. But definitely the design stage is very important, because this is where you think about the biases and you try to design a study that will end in minimal flaws in the method, and will result in as much as possible minimum biases and errors. When you have a bias, irrespective of the bias that you do, whether it is in the planning stage or in the implementation or in the interpretation stage, the result is the same, because what you will be ending up with is an incorrect estimate of the measures of occurrence. For instance, if you are measuring prevalence and you took a sample of volunteers, so this is an incorrect estimate of the measure of occurrence, and it will be, and if you have an association, there will be an erroneous estimate or a biased estimate of the association between your exposure and risk of the disease. So whichever stage you are into, the result would be the same. Your study is internally not valid because of the biases that you have introduced or have been either introduced inadvertently when you implement it, or that been used that haven't been thought well about when you were planning the study. And biases are so many. There is this alphabetical list of biases. So there is really an alphabetical list from A maybe to Z that you can find. I can give you the link to that article. From allocation, apprehension bias, ascertainment bias, Bergson, Sentry, some of them I actually don't know them at all. Compliance, confounding by group, detection, these are, we know, and then so the list is an endless list. So going back, and so when we design a study, we always take a sample of people, a sample of cases, we take a population, we follow them up, we never take the full population, and we have errors or biases. So it's always important to differentiate between an error, which is a random error, and a bias. And this is something that you've already taken. I think we've already talked about it. Maybe in sampling we talked about it. That the random error is, which is the lack of precision. Yani you have a measurement, but it's not precise. It varies, but it does not distort your mean. For instance, this portion of variation is due to chance. So people vary around a certain characteristic, but overall, even if people vary, you will end up, if you take that sample of people randomly, for instance, so if you take a random sample of people, get their mean, people will not be the same, right? So there will be variation. They will not all have the mean of that distribution, but if you take them all, they will have that means together, right? So if you look at this, this is for targeting. So if you want to have a prevalence of smoking at AUB, you take different random sample, and then you will have those different points, but they are very close to the mean, right? They are not so dispersed, but ultimately they will give you. So this is the blue is the green is the distribution with random error, and the blue is the actual distribution with no random error. So you see that there is a variation, but both distribution will end up with the same mean. So this is random error, and this is something that we can actually measure. So it's sampling error. So sampling error is something that we can measure. That variability of the data that does not affect the mean of the group is usually caused by chance, and it is something that we can measure and report on. However, bias is more of a systematic error, which we know the source of, and we want to remove the source, and it's giving a wrong information in a particular direction. For instance, if you use a scale, that's always increasing the weight of the people who are being weighed in a sample. So this is actually always deviating from the mean, to the extent that when you take the mean of your sample, it will be higher than their actual mean of the group, because although it's equal, but it's always inflating the mean, right? So therefore, this distribution, which is the blue one here, it has systematic error because it is around the mean. However, the red, systematic error, excuse me, so the mean is here, and then the red one is deviating from the mean, and therefore it does affect the average, and we call this as a bias. Okay, so if you see it as the target here, even though people are around a certain mean, it's around each other, but they are far from the target, which is the mean inside. Okay? And sometimes, of course, some errors or some differences can be all over the place. They can be, they can inflate, or they can give lower mean. So as long as the mean, so those variability, they don't affect the mean of the sample, we're good. But when they affect the mean of the sample, this is an error. Okay, so why is biases important? Because if we're talking about association, so association can be created when actually there's none. So, and we call this bias away from the null. So the null is one, let's say an OR. So when we take for instance, when we consider smoking and lung cancer, and we ask people those who have lung cancer to recall smoking, and they are more likely to recall smoking because they have lung cancer. So what we find is that the OR of smoking and cancer is way higher than the actual. So it's biased away from the null to a higher OR because of a recall bias, which is differential for cases. The bias can also mask an association when there is actually really one, which is bias towards the null. And it can be primarily introduced, as we said, bias is by investigator or the study participant. So this is something that either the investigator, when planning, has introduced, or the study participant when they answered the information, when they left the study, when they refused to be part of the study, the way they are giving me the information, if the questions are not good, or if they have in an interview format, sometimes the participant does not give the right answer because of social desirability bias. So they want to please the person. They don't want to tell you something that's not socially desirable. So therefore, the bias would be introduced not only by investigator, but the actual people who are part of the study. So all studies have bias, and it can't be that studies don't have bias, but it's actually the magnitude of the bias and how much the bias affect your result is what's important. So I cannot pretend that now, with all the quality control that we're putting in the study, the training, the rigorous construction of the questionnaire, that will end up with a bias-free Al-Sahha, for instance, our cohort study. Definitely not, because there will be always something in the field that might go wrong. The issue is that how much of this bias is affecting my result. But of course, I need to know what is the type of bias and when does it occur. So when did, for instance, selection bias occur in my trial? Do I have information bias? And what kind of information bias I have or I might have? How much, as I said, how much it affects, how much is the effect, the magnitude, and what's the direction of the effect? I mean, this being said, that let's say I lost some of my participants as I am following them up. So I lost these people. This is their characteristic. So what would happen to the association at a later stage? Okay. So, oops, why it doesn't show this? So this is like, okay, so the first one is a random error. I'm sorry that it does not show much. The first one is when you take the mass of a ring and you measure it 3 times and then get slightly different value. This is more a random variation. And how you minimize, so if you see the value are 17.46 grams, 17.42, and 17.44. If you're using the same balance and the balance is a good balance. And this variation can actually be reduced when you average the observation and when you take more data. So the more data, the smaller the variation, right? But if you take a cloth tape measure that's torn and then and it's been stretched out over the years, so stretch out, it means that every time you take the scale, it will add up 0.0 gram, which is higher than all the measurement. And then that will create a systematic error because the mean of those measurements will be higher than the actual mean because of that measurement error, because of this torn or tape that does not work anymore. It's like when you use something that's not calibrated. And people don't measure it well because they are not calibrated to see the actual measurement, or a scale that you use at home that's always gives you an additional 1 or 2 kilos. Okay, so this is a systematic error. This is not a random error. Okay. So how does it affect? I think this is not the first time I'll show you this slide. And this slide came every time we talk about how to evaluate the presence of a valid association. So the first thing is the chance to think that there is always a random variation from one sample to the other. And that random variation, as we said, is reduced when the sample size is large. And that's why If you recall, when we look at the confidence interval, the larger the sample size, the narrower is the confidence interval. It means less variability. So the precision is higher because your confidence interval would be not shorter, what we mean narrower, right? And then how we measure it, we measure the associated probability of error by the p-value. So therefore we can measure it. With it, we measure the confidence interval. But then we evaluate them. Then the association, okay, it's significant. So let's see, even significant or not significant. So I have to think and reflect, is the design or the conduct of my study, the way I have put things in place, my tools, my indicators, and the way I have collected or I have defined my cases, control, the way I collected data in the field. Is there any room for introducing a systematic bias? Then I go into how I selected the population or the sample or the cohort, and then if I have any information bias, and I reflect. Do I have potential for this? And if I have potential for this, as I told you before, it's not about saying, oh, well, there might be some selection bias. So if there is a selection, a potential, how would that affect your measure of association? If you think that one of the questions that you have asked is not actually giving you a right answer, and this is not a correct answer, neither for cases nor for control, neither for exposed nor for unexposed, then how it will affect the OR or the relative risk? Would it affect it differentially or non-differentially? So this is a very important element, is to make sure that the bias is being studied, is being reflected upon. So you need to examine and evaluate bias and talk about potential and whether you have it or not, and if you have it, how it would affect your result, okay? And then confounding, as I said, I think, I don't know if I told you earlier, before when we talk about bias, we'd say information, selection, and confounding bias. And confounding is not, if you recall when we talked about confounding, is not a bias, but we want to take care of it. It's an indirect association that we want to remove. It's a noise around an association that we want to remove. And then we control for it either, we control for it either by design, so we restrict, or we do matching, or we control for it in the analysis either by stratification or by control and regression analysis. Okay, we're good. Okay, so we'll start with the selection bias. So selection bias, it's actually related to an error that I commit when I systematically I introduce an error because of the procedure I use, either when I recruit meaning I select my subject, or from factors that affect the study participation or retention. So these two large factors are related to the study design. So when I say I recruit or select subject, it could be selecting of a random sample for the cross-sectional study. It could be selecting a random sample for sometimes the baseline cohort, or it could be how to select my cases and the control. How am I recruiting people to my study? Are they voluntary? Are they random? And the selection of the cases and the control, now, based on now what are the parameters and what are the important the design issue and in case and control selection, that they are very, very important. So therefore, the main source of the bias could be at the selection phase, right? So sampling, so non-random sampling, convenience sampling, and selecting only those who survived. So those who survived, which is survival bias, وهلا بنشوفها بالcase control, because let's say if you're looking at cases of cancer and you take incident cases, but however, the cancer has a very high fatality rate, and by the time you identify those cases, many of them would have died. So there is a survival bias because you are ending up with people who have survived, who might be maybe less severe. So this is in the selection phase. Okay, the non-random sampling, we'll talk about it with the cross section. So convenience sampling, and I want to talk about convenience sample, and maybe I talked about it with the sampling before. Sometimes this is the only way of collecting the data. And I want to hear from you. What did you, for those who have attended, so did you hear anyone talk about random sampling yesterday? How did the medical students select?
Mostly
How did they
convenience
select it?
sampling. I
Yes,
didn't hear anything random, doctor.
it's true. Yes, مظبوط. So it was لأنه they did most of them. How were they done? At least if, maybe I'm sure at least the great majority. I think you heard the people who sent the Lime survey, right? So the Lime survey, they put it on social media. They used the WhatsApp group. So they don't have actually a sampling frame, right? They don't have a list of people from which they selected a random sample, right? They don't have a frame, meaning that they don't have like a list of courses at AUB and they selected and even in when they did the medical student, Med 1, Med 2, Med 3, Med 4, they took all Med 3, Med 4. So it's like volunteering, right? So whoever, so it's not like, so everyone was invited, not even a random sample. But for those people who use Lime survey on social media, it's a convenience sample. We don't know what's the probability of each one of being selected. So there will be definitely a higher proportion of those who use social media. Are they different from those who don't use? Of course, right? Are they different in terms of literacy? Yes. They might be different in many instances from the population. And I want adult population. So who are the people who are responding on social media? What's the baseline population? I don't know. But what we do, what we try to do on social media again is to get as many a variety as possible. But then the issue is it's not to come up with a value like 20% of the adult, they smoke, they vape. No, 20% of a sample of those who responded to me, they vape, right? So the inference to the population might be really, really problematic. Unless I know from the background and the characteristic of those people who responded that they, to some extent, represent a wide variety of people. Did you get me? And I want to give an example from AUB. If you don't have the mean nor the time, and you don't have access to any list from AUB student or list of classes, you decide, for instance, each one of you to go to different spots at AUB campus and approach students who are on campus, lower campus, upper campus, IC gate, medical gate, etc. So this is a convenient sample, right? But by diversifying the place where you got those people, at least you ensure that you have covered students from different faculty, مظبوط, because of course the engineering would not be at the medical gate. Engineering would be on the lower campus. FAF student would be in the lower campus, so on and so forth. So diversifying where you're taking your sample without having a sampling frame, would ensure some kind of a representativeness of the sample, but it's still not representative. Participation is important in the selection phase. So you approach people, they refuse to participate. We always have to report the percent who did not respond or who refused, and what's their characteristic. And this is selection bias. So this refusal might introduce selection bias. Why? Why would it introduce a selection bias if people refuse?
Maybe they have different characteristics than those who included in our study.
So not like this, but yeah, which means ultimately what does it do? It means that I don't have anymore the population. I mean the characteristic of I'm not representing the population, the target population that I want to represent, right? Because if the characteristic is different, it means what I'm left are with a particular group. So therefore, the estimate are not the estimate of the original population. They are the estimate of those who were who actually accepted to be in the study, but they're not representing the whole population. And the participation, we have the non-response. This is all at the level of the selection, right? And then the volunteer bias. And when people volunteer, and instead of selecting, so let's say you put a flyer in the health services, you put a flyer here on one of the billboard, and you invite people to be part of your study. This is volunteer. So people who are interested, let's say study is about case control and family history of case control, cancer, breast cancer, and family history. So maybe people who have in the family breast cancer cases or family history will be more likely to volunteer as control, for instance, right? So the selection phase as well is an appropriate choice of a comparison group, unexposed cohort, for instance. If you recall, in the case control, for instance, if you take a lung cancer and then you pick up people who have COPD. The other one selection is the retention phase. The selection, and we introduce selection bias either at the selection phase when we select, or when we are following up in longitudinal cohort, because you start with people in the cohort and you want to follow up to see who will develop the event. So if people are lost to follow up, so you at the end, your outcome and your conclusion can be different, depends on who actually left the study. Why did they drop from the study? So that what we call lost to follow up or attrition and longitudinal study. So we call it retention. But I want to tell you that this is very difficult. It's true there is some kind of a field called bias analysis, but it's very hard to correct the bias. So what we do is we can do sensitivity analysis. So we look at the data with and without. We try to see how this is affecting the data, but it's very difficult to correct the bias in the analysis because the damage is almost done. So this is the sample. So this is my reference population. The big one is the reference population. And then, so this is the reference. I have 4 group when I do a 2x2 table. And the population is made of diseased and exposed, healthy and exposed, but we have also diseased who are not exposed and healthy who are unexposed, yes? So forget about case control. So when I take a study sample, I want my study sample to represent the same probability as here. So if this is a 68%, okay, so the probability of selection is 68%, this is here, it should be the same. And when this, for instance, if I select in my sample, I have a higher probability of including disease who are exposed. فنقول إنه you go and you try to get مثلا أنا بقول I want to do a study on pregnancy and smoking, and I don't know why people directly think that I want to recruit smoking mother. No, I don't want smoking mother and who have issues. I want mother, and then I want to ask her about smoking. So when I have a tendency to include more mothers who had the health problem because they are smoker, then this would distort the study sample, and I would be taking higher probability from this, and therefore I would have an erroneous or a biased association. It's similar like here. This is cross-sectional. This is my population. These are the people, the yellow dots, who have the disease. So if I have to select a sample, representative sample, at least the proportion of disease, non-disease should be almost the same. If I get this kind of sample, do you think this is representative? يعني what are the odds أنه أنا نقيت 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 2 out of the 13 are diseased, where here it looks like 50-50, right? Or maybe 40-60, right? So the population, we're not going to count the circle, but this one looks like the yellow dots are almost 50-50, right? And then I select to look at the probability of the disease, and then this is what I get. So is this a representative sample of the population?
No, like
No.
since 11 are diseased.
Yes, because it cannot be, yani, what a poor sample. So you have to ask, I mean, you have to be critical. Yani, therefore, no, from that sample, each one of you can select a different sample, even randomly, right? Then all, no, you number all those, you put them in a random, and you ask the computer to generate a sample of 13. You know that you will have hundreds of possible sample. And one of your sample can look like this, but the probability of sample like this would be very low. So your probability of getting a sample with very low number of non-disease is very, there is a low probability. However, if you do it in a voluntary manner, you might end up with this. And then you look and you say, no, this is not a good sample. So you have to be critical about the sample you select. So that's why the selection bias and cross-sectional design, you have to ask yourself those questions that we have already seen. So was the study population clearly defined? Because when it is clearly defined, you will be able to get to identify a sampling frame and clearly put a sampling frame that is a random and do a random selection. Was the sampling frame adequate and complete? So sometimes I know the population, so I want a school student. So, and then you go and you get, you did it, I think, in the cross-section, right? So many of you, or maybe all the 5 group picked up schools, right? Adolescent schools. So did you check whether the frame or the list of schools from the Ministry of Education and Higher Education is up to date? Does it have all the schools? Does it have enough information on the schools? So if we know that the MEHE has been so non-functional, it means that I don't expect them to give me a complete list. So therefore, if the sampling frame is inadequate, this means that I'm selecting a sample, though it's random, but from an inadequate sampling frame, so I have a biased sample. Was selection done using probability? Of course, random give better result, less bias. No. Were refusal kept to a minimum? And if there are refusal or non-response, we always have to check whether the responder are different from non-responder. Okay, so this is an example actually of a good study. This is a survey of students following the implementation of a university smoke-free campus. That was done in 2008-09. So, but this was published in 2013. I think 2008-09 or before we had so around this time, we had this free campus. So we want to see or we established it, or we put it in place. So we wanted to see what's the attitude of the student. So we took a random sample of classes during the spring semester. So the total number of students in those classes was 545. They were registered, 545 registered. None of the instructor refused to allow recruitment in their classroom. So this is a different study from one of the study that I told you about. And then, so no refusal at the level of the instructor. And the sample was proportionate from all 6 faculties. The students who were attending the chosen classes were approached and asked to complete the survey. Of the 545 approached, fewer than 2% refused to participate. So the final sample included 535 participants, of which 25% were foreign. What do you think about it? What's the probability of selection bias here? Would you worry about selection bias?
Not really, because like 2% only refuse to participate.
So the response is very low. Yes, Yasin. I'd like to hear from others. Are you with me? Are you online? Okay. So I will be calling on people. Celine, what are your thoughts on this sampling? Is there possibility for the selection bias? Unless Celine is not here. Okay, so now I wanted to see who's here. Okay, كأنه سليم مش هون. Participant 14. Okay, so Nadine, what are your thoughts on this? Is it because we're online, you're not interacting? Are you just opening the lecture and just listening?
Hi, doctor.
Hello.
Okay, so I agree with Yassine. We don't really care much about selection bias because the percentage of refusal is very low, and most of the participants did respond.
Okay, so but what they said, the only thing they said that we had some oversampling from the Faculty of Health Sciences, which is fine, that we can always account for. We do some post-weighing in the analysis, so we can restore the balance. تتذكروا الويت what Aya Samad presented to you? Do you recall the
Doctor,
weights?
in the Sahha study.
مظبوط. So in the Al-Sahha study, we ended up with a higher proportion of female than the normal proportion in the population. Although it was again randomly selected, but it depended on the people at the time who were in the household. So we introduce weight in the analysis to restore, and the Faculty of Health Sciences accounts for like 4% of the total population of AUB. So if the sample by chance had a higher oversampled from the Faculty of Health Sciences, then what you do is you try to suppress or reduce its contribution to the sample by including weights. Okay, so that's, and the mostly so and cross-section study is about really random sample, and it's about random sample, volunteer and non-response. So you want to make sure that you do it randomly, and of course again acknowledging that we might not be able to do a random if there is no frame, nothing, no map, you're definitely not able to do it or to have a sampling frame because of the time, resources, and unavailability. And then you have so you do convenient, or your people are volunteered into your research, so therefore كمان you are introducing selection bias. And if you lose people because of their just either non-response to Lyme survey, if you're doing it online, or when you approach them in a face-to-face interview and they say, I don't want to take part in your study. And a select. Okay, so in case control study, selection bias is, again, we always ask ourselves these questions. So did the control represent the population from which the cases arose? Was the identification and selection of both cases and the control influenced by their exposure status? This is very important, so that cases and controls are selected independently of the exposure under question. So I wouldn't select a case known to have the exposure, like I would be looking and diagnosing lung cancer when I know the person is a smoker. And the controls is also controls. I'm choosing control who are non-smoker. That's not the case. Controls are people who don't have the disease. But of course, it's not only this. The controls is an issue also of I'll give you an example, and the exposure in place. So people are not being chosen as, for instance, hospital control, and they come to that hospital and I take those control, but those control, they don't represent the population from which the cases are coming from, because around the hospital it's low SCS, and SCS is a main exposure, and therefore my control are not the best control I can take. So selection bias can end case control might lead to misclassification of the case control exposure, which actually will compromise the estimate of the misclassification. مش انه الكيس بصير control والcontrol بصير case, بس I mean in terms of case exposed, control exposed, or case unexposed and control unexposed. So this is an example. It's a nice example, and you'll see how it will affect. So this is a study where we wanted to see whether women of low SCS have higher risk of cervical cancer. We have 100 hospital cases, and then the author chooses to take 200 controls doing a door-to-door survey of neighborhood around the hospital during workday. Okay, so door-to-door survey, so great. And we're taking, so the researcher would think that the best would be a population-based control. But which population they use the population of the hospital neighborhood and during workday. So the socioeconomic status of those people living around the hospital may generally be different from the population that produced the case. يعني نحن هلا, can you take controls for any case that you take from AUBMC? Can you take controls from Ras Beirut? If yes, why? And if no, why?
No, we can't.
Rita, Ranim, or Rita, whoever. Do you think
No.
that if you take, no, it's accessible. يعني أنا as a researcher, or you, if a PhD student, you want to do a case control, you would tell me, doctor, I'll pick up some cases and maybe I can do a door-to-door survey in this area I'm comfortable with, is accessible. Do you think this would be good? And why yes? And
No,
if
it's
no,
not
why?
good.
Why?
Because if we take a sample from AUBMC, it's not just one geographic area in Lebanon. So AUBMC is covering all Lebanon, and patients can be from anywhere. So comparing it to only one area in Lebanon that is maybe of a certain socioeconomic status, of a certain literacy status, so it won't be a good comparison in a sense.
The problem is when we have an exposure that could be related. I mean, that could alter. Like here, we're looking at low SCS and risk of cervical cancer, and we are taking control who are most likely to be of low SCS because of their head. So that's the extreme case. Again, as you properly said, rightfully said, AUB has a wide catchment area. So therefore, controls from the neighborhood would not be the control and will not represent the population from that where cases arose, right? So نحن بدنا ناخذهم من نفس population كأنه cohort ماشيين مع يعني we always think about the cases and the control as being they coming from a cohort in the past. They marched together, and then some of them became cases and the majority were controls, right? مش هيك we were imagining. No, it's true. We start with the case and then we take the control. But we have to put on the back of our mind is that those cases and the control, they come from the same population that marched together in the past to reach that now. And some of them, they were diagnosed, others were not diagnosed. So therefore, the method of door-to-door method here tend to select control that may have more lower or maybe higher, depends on the neighborhood, right? So what happens? So let's see it as in terms of the population. Okay, so here is the population. So the population of disease, let's say cervical cancer versus control, and then low SCS versus no SCS. Let's say that this is the actual distribution, right? We have 75 here, 100 here, 2,500, and the truth is that this would result in an OR of 3. So this is the population. Let's say we know the population. And then what we did here in the example that I just show you is that we oversampled that cell. And that cell, the probability of selecting was higher. So we selected higher than what's actually is the probability of non-diseased and exposed, non-diseased and low SCS. Did you get me? شو عملنا? What happened there? In the population, we expect that we have 100 controls who are exposed. When we selected the controls around the hospital, we ended up with 120 because we increased the probability of people with low SCS. عم نحكي عن low SCS. So what happened if you increase this one? الodds هو 75 over 25 over 120 over 80. So we كبرنا. So this one was inflated. So صار في more control who are exposed than the actual is. So what happened to the OR? It went to the null. So it went to the null. So the OR was reduced because of a poor selection of my control. Is that clear?
Yes,
clear
Yes.
it
doctor.
is.
Okay, great. So here مثل ما قلنا عم نقول 50% 50% هون طلعت أكثر من 50 almost 60%. Okay, great. So this is another example. Okay, so this is another example. So this is a comparison of control of the odds ratio of birth defect and maternal diabetes for two controls group. So maternal diabetes is an exposure, and they're trying to have two cases, cases where they have central nervous system defect and cases where they have cardiac defect. So when they took normal controls, so from the hospital, but normal, so with no defect at all, so the OR of maternal diabetes, if people have for cases, was 1.86 that of control. Okay, so higher diabetic, not significant. But if you look at the OR when they took other defect, the OR is smaller, right? هلا أكيد it's not significant here. So do you follow my cursor? Do you see my cursor?
Yes.
Okay,
Yes, we can
so
see.
186, it is 115. Both of them are not significant, but just look at the effect size. So 186, 115. When they took cardiac effect as the cases, and they compared to normal control, the OR was 3.09, statistically significant. When they use other defects, it dropped. And the OR was biased towards the 9. So did you get what happens? Because maternal diabetes can be associated with those other defects that we don't know what other defect. Because other defect might be, maternal diabetes might be actually a known exposure of some of the other defect. So taking other defect as control for those who have birth defect like cardiac or central nervous system would not be actually a good control group. We're good?
Yes.
شفتوا قد ايه انه it's really important, not also the cases how they are selected, but the very قلت لكم it's one of the most important issue is the issue of the control, how the comparison group counterfactual. Who's your counterfactual, right?
It's the
who's the
first
counterfactual?
It's the first
So
time أصلا we visualize هيك كيف بس يتغير الكنترولز بيأثر على
ما هيك؟
النمبرز تبعنا. Yes.
Okay, so that's what happens. كمان can be another way of introducing selection bias and case control is when you self-select. So when people are tend to participate, if actually they are interested in both if they know if they have an interest in the exposure or because of the outcome, for instance. So, for instance, example, a case control study that explored association between family history of heart disease as an exposure and the presence of heart disease in subject. So volunteers are recruited from an HMO. So subject with heart disease may be more likely to participate if they have a family history of disease. So how to address it? I think there would be a question from you, how to address it. That's why we blind many a time. We don't say which is what is the exact hypothesis, right? So we say that we're looking at risk factor, and then we blind the participant about the exact history, the exact hypothesis, or actually the assessor as well. So blinding both the participant and the person who assesses. يعني لأنه إذا كمان person knows about the family history, they'd be more likely to probe, or vice versa. So if we can see it visually, okay, so here is that relates actually to the same example, هلا على family history. So this is the truth, where you have again the OR of this 2.25 to have a family history. If people have the family history associated with the higher odds of the disease, right? And then you do the selection, and then you have more of the people who participate because they have the disease. So you are again oversampling here. So 80%, هون 300 200 قد ايه بيعملوا تقريبا the actual probability here is lower. So هون عم ناخد the probability to be selected much higher than the actual probability. So we are oversampling, we are getting a higher group than the actual. So higher group than the actual. What exists in the population of cases who have the disease and who have the family history. So there are cases and there are parts, so they have self-selected because of family history, and therefore this self-selection bias, which can go either way, by the way, you select yourself in or out, right? In or out, or the controls, they are selected because they don't have. Only the cases were self-selected because they have. So therefore the OR was away from the null. Okay, so it can go either way. Okay, so best solution is to work toward high participation, so more than 80% actually in all group. So نعمل high participation in all group, or we make sure that this is actually the same participation of the other. So هون شو صار إنه the highest participation كانوا from those cases who were so this is sorry, maybe I got it wrong. So this is the 60% from these people, right? So now we have a higher proportion of those who participated who came from that group. So to restore this, or to have a better result, is to ensure that the participation rate from all of them is 80% and not over participation from one group to the extent that it distorts my OR. So I'm going to, I found these today, actually. I had used them in another course and I like them. I don't recall actually from where I got them. I'm really sorry, but I had them in my slide in an earlier presentation. So this is another one. So case control has plenty, as you see, it's a list of biases. So this is a nice one on incident prevalence, Niemann bias, بنسميها Niemann bias. So when you pick up prevalent cases, okay. So here is case control study. They were looking at tobacco smoking and acute myocardial infarction, AMI. So the cases were interviewed 1 week after the coronary attack. But the problem is, or the scenario is, what if a smoker patient with acute myocardial infarction, they die more frequently? So they die, so their survival is really shorter than non-smoker patient. So how will this affect my estimate? So again, this is the population, and these are the people I am selecting. So if I'm selecting, I'm ending up with cases, smaller proportion of cases who are smoker, not because of anything, but that I'm missing those who are cases and smoking, because those smokers are more likely to be not to be there. Okay, so the leaving cases will show lower frequency of smoking, and therefore underestimation of the association between smoking and AMI. And we lost those people who were smoking, they died. So we are left with people who survived, who are still alive, but the control are more likely to be smokers. So we don't have this high number here because they already died. So the odds ratio decreases. And there is another one, which is the overrepresentation of cases with, let's say, here with the respiratory diseases, where again, the issue is overrepresenting one of the cases. And which group am I over or underrepresenting might lead to biasing my OR. So in this case, again, we are looking at case control and smoker, non-smoker. And if people are more likely to be hospitalized if they have 2 or more disease rather than only one. So we have a higher exposure rate among hospital patients as compared to the general population. It's because of hospitalization, right? So they are more likely to be hospitalized. So عم بخدهم أنا hospital cases. So definitely they have a higher exposure, and therefore it will be biased towards it will be inflated my OR. So how to minimize selection bias and case control? So whenever possible, cases and control could be selected from entire community, which We don't have, especially if we don't have registries, and we don't have even the hospital registry, they don't represent all the communities. Compare exposure of the control to data from survey of general population. Yani, so to know that your control is a proper control, you see you need to see that the prevalence of the exposure and the control actually represent the overall population. We talked about smoking at the time when we talk about case control. And if hospital control need to be used, there should be explicit criteria why we are selecting hospital control, and ensure high response or participation for both cases and control, and not like over-representation of one of the groups. So بالcohort, how were the study groups selected or defined? So again, how did we select our cohort? How much participation? Are the participants similar to non-participant, and how complete is the follow-up? And we know that the most important one is the loss to follow-up, because it can create a very important selection bias. Okay, I'm just aware of the time, and I want a sip of water. So when we bring in participant to a cohort study, the outcome did not happen at the time, right? So definitely enrollment in a prospective study is not biased by what will happen. So they will not say I'm more likely to die or to develop a CVD, and therefore I want to be part of the study. Sometimes it does happen if you have like family history of, let's say, dementia, but usually it's not affected by the outcome, because at the time outcome has not occurred. So the two important issue of the prospective study, as we said, is the retention. The most important is when we select, but the most important is the retention. So as an example, there was a prospective study of women over 10 years to determine if alcohol consumption that was measured at baseline would increase the risk of breast cancer. So they didn't find any statistically significant association between alcohol consumption and then 10-year incidence of breast cancer. And then they found out that out of the women who were enrolled at the beginning, so they approached 12,000 women. They were enrolled in the study at its initiation. So the 12,000 were, but during the follow-up, those 10-year follow-up, 3,458 had withdrawn. So this is so how many they retained? They retained 8,000, but they lost the 3,500. What do they know about the 3,500? They know about their baseline, مظبوط? They know that baseline, if they had high or low alcohol consumption, but they don't know what happened to them, because these people had withdrawn from the study during the 10-year period. So what to do is, this study, they followed up with spouses, friends, and relatives, and what they found is that those who withdrew, they have more than 60%, they develop breast cancer. So high proportion of those who withdrew, they developed the breast cancer, and 84 of them were regular drinkers. So what happened is that those that withdrew are more likely. So we lost those who are regular drinker and who had breast cancer, right? Right, guys? So with 8542 that were followed up, these were put into exposed, non-exposed, breast cancer, and no breast cancer. However, the case where we have breast cancer and regular drinker, we lost 3,000. So what do you expect? I would expect an OR that will be over or underestimated if we lost those who are breast cancer and who are regular drinker.
Underestimated.
Underestimated, bravo. So we would be underestimating actually the association between breast cancer and drinking, because we lost those who, and it's really of sufficient magnitude, we lost those. We don't always know that, right? You know that. People don't always call spouses and friends, but at least we would know who we lost. So if we are able, if the researcher was able to do some further investigation to know what happened to these people who decided to withdraw. Okay. And then they can report what would be the bias. And if not, there should be some scenarios that would be put to say that if those who withdrew have a larger proportion of them would develop breast cancer, this means that we are underestimating. So if, let's say, based on the 8,542, we found an OR of 4 and significant, I'm comfortable to say that since I lost a high proportion of those who were regular drinker, this OR of 5 or 4 is actually an underestimate. And therefore, I would say I'm pretty confident that regular drinking is related to breast cancer. Did you get me? So Anna, if with these people who were lost to follow up, I have an OR that's significant and it's 4. So what should I say? I don't have the information, but I know that I have a big number who withdrew and they were regular drinker. Most of them were regular drinker. شو فيني أقول? At least فيني أقول إنه and those who stayed, I have an OR of 4. And if I lost people who are regular drinker who might be more likely to develop breast cancer, so I'm very confident that there is a strong association, and what I see is actually an underestimate. So I expect a higher OR. Did you get me how people reflect? So people بيقولوا wow لقيت أنا association, but even this association would be stronger if these people did not withdraw. So that would give you, so this is the example, another example of differential loss to follow up in a prospective cohort study on oral contraceptive and thromboembolism. So again, the truth, so this is the same exercise as we took and in the case control. So the truth is a relative risk of 2, meaning that out of the 10,000 who used oral contraceptive, 20 have thromboembolism. So it is 20 over 10,000. And 10 out of the 10,000 have had a thromboembolism event out of those who did not take oral contraceptive or reported not taking oral contraceptive at baseline, with a relative risk of 2. Okay, because they have the same, they chose to have the same 10,000 oral contraceptive, 10,000 with no oral contraceptive. So let's say that during the follow-up of those 10,000, we had the 40% loss to follow-up overall. So people, you follow up on women, and women decide not to be part. But there was a greater tendency to lose oral contraceptive user with the thromboembolism. So this result in a de facto selection. So now we have 8 and 8. So therefore, now what's the relative risk now? So we lost more. يعني نحن هون 20 و 10, right? وقلنا we lost more people here in that category. So if this has happened differentially, so therefore now the relative risk is 1. Okay, so what happened is that because of the differential loss to follow up, so we lost more of people who are OC user and who have thromboembolism. So we lost more than what we should have, and it's differential. So we ended up with a relative risk of 1, which is really different from the truth of 2. هي مثل السمokers فرجيتكم إياها هلا. So if you lose this, sorry, no, not this one, this one. So أخذت 2 cases, and then you end up with cases, less number of cases who are smokers. So you ended up with an OR that is less than what it's supposed to be, and maybe it goes to the null. Okay, so that's so again, non-participation in a prospective study as well could result in a selection bias. So let's say we invited 100,000, so 25% are smoker, 50% agree, and then 50% refuse to be part. So it's a large population. And then out of those who agree, 20% are smoker and 30% are smoker of those who refuse. So a higher proportion of those who refused were smoker. Okay, so what we notice here is that a higher proportion of those who refused were smoker. So who are we looking at now? At those who agree. So what happened with those who agree? 10,000 smoker and then 10% have MI, 40% are non-smoker, and 5% have MI. So what's the relative risk is 2. So if we look at the smoker, and they have the same percent of those who refuse, the same percent of risk of MI, and not a higher percent of MI. So therefore, the relative risk remained the same. So therefore, now we lost those people, but we did not actually change here. So because again, the 50%, those 30% who smoke, again, are divided into 15% who smoker and 30% non-smoker. But within the smoker, we have the same probability of MI. So therefore, we did not have any bias. So although we have a high refusal, but it did not result in any biased talk. So that's for selection bias. And there is actually a lot of other types of selection bias, but these are the most common selection bias that we talked about. And then, of course, we have information bias. The information bias occurred when the way we are collecting the data is not appropriate, and it is actually resulting in systematic error in both measurement of exposure and outcome. And they can be actually divided into the way we can present them are outcome identification bias and exposure identification bias. So if we're talking about disease, for instance, incorrect diagnosis, if we're not specifically doing ascertainment of the disease, the diagnosis is based on self-reported of the disease status. If we are using records that are incorrectly coded, so this is something that we have to think about. Where is it coming from? Where is the information bias? So and that's why you always have to question how people are collecting the data. Where are they collecting the data? What's the source of data? Exposure, for instance, imprecise measurement. Where do we get imprecise measurement? When we don't have a good questionnaire, we don't have good indicators. We have a device that's not calibrated, and it's not a good device. And the database, I have a lot of uncertainty how a database in a database that already exists, they have measured the exposure. Of course, self-report of exposure, people recalling better than others. And all the biases that come when there is an interviewer, part of the data collection. Not all data collection have interviewer. Some of them are self-administered, Lyme survey. But when you have an interviewer, then you have to think about the biases introduced by interviewers. One of them is a lot of probing. Some of them are, so there is a list of interviewer-associated biases. So when error and exposure also occur with approximately equal frequency and groups being compared, sometimes in a database, everything is not recorded, the coding and recording is the same. Or we use surrogate measure of exposure. So we don't use the exact exposure. We use prescription for antihypertensive. So sometimes it's not, so the non-differential happens the same. So sorry, when we talk about information, we are afraid of differential or non-differential, meaning that so the error would be the same whether you are a case or a control, whether you are exposed or non-exposed, the error is the same. And this comes from errors in the databases, or if you're measuring, for instance, high hypertension by asking, have you ever been diagnosed? So it's a question. Or when you use broad definition of exposure, like do you smoke, rather than defining exactly what type of tobacco smoke and the frequency and the severity of smoking. Differential diagnosis, differential misclassification, and this is actually the most important one, is that when there is the errors are more frequent in one group versus the other, either in the exposed versus non-exposed, or in the control, more in the cases than in the control. For instance, differential misclassification can happen when there's differences in accurately remembering exposure. For instance, people who are depressed, who are more likely to recall bad event than people who are not depressed. So cases more likely to recall. So this is the recall bias that most of the time is differential for case control. But if you're doing a cross-section study and عم تسألوا العالم مثلا about war event, it will be the same. But if people are diseased and you're asking them about stress, they are more likely to remember. Interviewer or recorder bias. So so this, I don't know what is it, how it can be differential. Interview has subconscious belief about the hypothesis. Okay, so when the interviewer, the person knows about the hypothesis, so they would be more likely to either probe or record information that's wrong for the case rather than the control, or again, more accurate information in one group versus in the other group. It depends. For instance, in a case control study, you take from hospital, and then the exposure is better kept than if you pick up control from and you're asking the different way of asking the information from cases and control. So أخذنا من hospital-based cases وأخذنا الcontrols, and then we're asking differently the data for cases under control. This also might so this is a way. Misclassification, when we think about misclassification, we think about specificity and sensitivity. So sensitivity and specificity is the ability of your measure to correctly identify people with the exposure, or the specificity is the ability of your measure to actually say that people are not exposed when they are actually not exposed, or disease when they're actually diseased versus non-disease when they're actually healthy. And if the tool is not sensitive or specific enough, what will happen is just see this scenario. So we have a true odds ratio of 4, and when the exposure is high and the specificity and sensitivity is high, the OR does not change much. But as the sensitivity and specificity changes, for instance, okay, and the prevalence of the disease is small, okay, we don't have too many people with the disease, so the OR that's 4 changes, and then it goes down and goes towards the null. So then what this slide saying is, if your measure, so that whatever you are actually collecting data on are not accurate, تذكروا what's the validity and the reliability, validity of measure, هي تكون specific or sensitive, right? So they are actually measuring what they intend to measure. So if this is poor, the psychometric is poor, so therefore the OR that you get, if the measure is not good, it does not reflect the truth, which is an odds ratio of 4. And this is, I think, the last, the one before, not the last slide, but the one before the last. Again, this is an example of bias in a case, information bias in a case control. We were looking at MI with dietary fat. So MI present are the cases and the control. So the truth is, so what's the odds of dietary low? So we're looking at high fat and MI. So 60 over 40, 60 over 40, over 40 over 60. So 60 times 6, so 60 times 60 over 40 times 40. So the truth is 2.25. So non-differential classification, if we 20% in the high, so this is the high, are misclassified as low. So then all the tool is not very accurate. So شو صار, irrespective whether people are cases or the control, the tool استعملته to define people as low or high dietary fat. حطيت الهاي منهم طلعوا 20% هن they were misclassified as low. All right. So a tool that's accurate. So شو صار? So I should have 60, right? So 20 of the 60, they went down to the low. With 20 of the 40, it went down to the low category. So what happened now with the OR? It became 1.96. So when there is a differential misclassification, sorry, non-differential, most of the time, the OR is attenuated. Not all the time goes to 1, but most of the time we reach a null. But when there is a differential misclassification, meaning that only among the control, some of the high went to the low. So شو تغير? Only this one. So this is did not change, but some of those who are controls who don't have MI, so some of the high were misclassified into low. That 20% happened only for one group. So what happened to the OR? It was inflated. لأنه أخذت أكثر controls who have low dietary fat, while and actually in reality some of the high fat in the control was misclassified as low fat. Did you understand me? Should I repeat?
All
Yes,
clear,
Doctor, clear.
doctor.
Are you sure? Okay. So only in one, the 20 and high fat misclassified. I don't know if you have seen this, and maybe in one of Dr. because this has been used several times, frequently with in several presentation, and I don't know if you have seen this with Dr. Gandour, but if you saw this is the second one you see this, it's good because this reinforces the idea of differential and non-differential misclassification, okay?
Doctor,
Yes. Yeah.
but you said most of the time the OR is
Goes to the
attenuated
null.
in the yes.
When
So in what case is it the reverse?
منه كتير reverse يعني but it will be attenuated, but sometimes it go to يعني لما كتير من الهاي بيصيروا low usually بيصير أكتر towards the ما في association.
Okay, thank you.
Okay, but it's not a rule. So when you see several articles or presentation, handouts, books, they tell you that when it's a differential misclassification, the association usually goes towards the null. And it's not null, but it goes toward the null. يعني كنا 2.25, it went down to 1.96. And in that case, لو كان بالعكس, if we had more of the low misclassified as high in the MI present, right, on the other side, we would have even much higher حتى. Okay, so ممكن يعني the OR can be inflated either way, either low صار بالهاي أكتر بالMI أو بس بالMI طلع عنا 32. ويمكن كان we might have a misclassification on the other side and in the other direction, and some of the low were misclassified, and that's why it's very important to reflect and examine your tools that you use. So when you interpret your study result, always ask yourself, given the condition, could bias have occurred? And is bias actually present? What are the consequences of the bias? This is very important. And which way it distort the measure of association, which direction, whether it's away from the null, so inflated, deflated, or towards the null, meaning that it becomes lower. I found this in one of also my presentation that I like. I have like 3-4 lecture on biases. I tried yesterday to look at all of them. So I used one that I used not last year, in the 320A that the MS only take, but I haven't been giving the 320A. حبيتها errors in research. So عندنا random error, method to increase sample size, and then selection bias, one of the most common ones, and then measurement bias, and then confounding bias, if you want to consider confounding, but something you always have to evaluate, and how we can decrease each one of them. So this is for final one for you to have. Okay, I think we're good. 324, I had the intention of finishing it in 1:15, so we started at 1. So any questions? Any questions for me before we close?
No, Doctor,
All
thank
clear,
you.
Doctor.
Okay, we're
Doctor,
good.
can
Yes,
you
please.
repeat what we need to focus on for the exam?
We need to focus on the designs and on being very critical about what in the design could improve or threaten validity. So what are the aspects of the design that's very important? Case control, cohort, and of course experimental. You have specific concept in experimental. You talk about blinding, randomization, etc. And of course how to analyze the data from those case control, cohort, and with a particular also emphasis on survival, and of course experimented with number needed to treat and treatment per protocol that you have also taken with Dr. Khalil. I don't know that maybe we didn't post the key for the Dr. Khalil's paper, right? So you had an exercise. Did you get any feedback from Dr. Asmar?
No, on the forum.
Yes.
We replied on the forum. No, we didn't get a feedback.
Okay, and I'll ask him to post the key to the exercise. Mahek, he asked you a question, right, on an article.
Yes.
Okay, so I'll ask him to post this. And I gave you some, and again, like a table to interpret, an abstract, a developed abstract, or maybe part of an article. I'm not sure because I have either both of them, so I don't know which one I'm going to put. It could be the method section and method section, like how the study was implemented, to think about potential areas for biases or for areas that might jeopardize validity of a study.
Okay,
Dr.
thank you.
Yes, and
Can we please?
it should be 1 hour and a half. I will not have like a 2-hour or 3-hour exam, right? Yes.
Doctor, can we please have the key for the survival analysis assignment that we did in class?
I thought that I put it. I thought that I put it. Okay, I have it actually. I will unhide it. Yeah.
Thank you so
Actually, I
much,
put it, but I don't have I did not run every single, but I told you in the key that,
Yeah.
for instance, age and gender and were not statistically associated with survival because based on the Kaplan-Meier, very few were, except that like maybe the quality of care and 2 things. But I have some of it, of course, some of the key. But I'm not sure. I did not. I put a key, but with not with all the output.
Okay, Doctor, thank you so much.
Okay. Any other question? Any other concerns? I'm always around. You can always come. You can answer. And if you think that the question is relevant to everyone, you can put it on WhatsApp or send me an email or pass by. And it's like in 2 weeks you have right? In 2 weeks you have your final exam.
Yes.
Okay, so good luck. So in the meantime, you have plenty of time to study. And I know that it's a tough semester for the MPH because you have 15 credit, unlike the others, but I'm sure that you'll do it.
Thank you so much, Doctor.
Oh, sorry, I did not have time to correct the case control. It's been crazy. So hopefully this weekend I will post the case control grade. I haven't touched them. Sorry.
It's okay.
Okay. So you will have
Dr.
them.
One time we asked you after
Okay.
class if it's possible to get.
Sorry, I don't hear you, Zahra.
Can you hear me?
Yes, I hear you now. Go ahead.
Sorry. I wanted
Yes.
to ask one time after class, we asked you and you suggested to post maybe a sample of a previous exam
I
to
did.
see.
I did post. I did
You
post.
posted.
Yes.
Thank you.
Did you check? Are you checking your Moodle?
Doctor, it's
Yes,
available.
I'm on it.
It is
بس
available. لا أنا أوقات
think-
بنسى أنا it's okay. I will pause and stop recording. Okay. Okay.